IC. Today we are going to share some interesting scenarios and hopefully learn a lot on mastering unusual scenarios of IOL implantation and explantation. To start the IC, I request my co-instructors to please occupy their seats on the chair. Dr. Sudeep Das, who will be speaking on innovations in IOL cutting and removal. Dr. Neha Dholakia is not here, but we will be sharing her work with her new IOL cutter. Dr. Sri Ganesh, who will be speaking on IOL explantation and fixation in complex situations. And Dr. Matthew Kurian will be speaking on surgical strategies for malpositioned and flipped ICLs. We'll start with Dr. Neha Dholakia's presentation on innovations in IOL cutting and removal devices. Can we have the video, please?
The dual purpose tip, Dr. The dual purpose tip, Dr. Neha Dholakia, India. This is my financial disclosure. Stop cutting, start slicing. This is the way the tip just slices through IOLs, just the way a tailor cuts through a taut cloth. The jaws of the tip do not open and close like a scissor. This is an opacified IOL which is being cut into 4 slivers, so a 6 mm IOL can be removed through a 2.2 mm opening without extension. Here we do not even need to put an IOL scaffold below, as the jaws do not open and close, thereby protecting the endothelium and the posterior capsule. This is another lens of lens pitting, where the lens is trisected and therefore removed through a 2.2 mm incision once again. Between each step, viscoelastic has to be injected so as to protect the endothelium, and on day 1 we see all patients with 6x6 vision and crystal clear corneas. This is a 32 diopter lens, very thick, hypermetropic patient with very shallow AC. The only way out would have been to extend the incision and create a lot of astigmatism. Here the lens was bisected at the optic, and the optic haptic junction was also cut and thereby removed through a 3 mm incision. The older methods to remove IOLs were either extending the incision or the twist and out technique, which is a very nice technique. However, the surgeon has to be skilled and very quick in doing the procedure. Also, sometimes in case of a posterior capsular rent, it is not advised. The oldest fashion is to bisect the lens with scissors into 2 parts and then remove it through a 3.2 mm incision. However, this leads to striate keratitis, corneal edema, and sometimes even Descemet's detachment on the second day. The tip is just like a phaco tip, but it is a solid metal tip made of titanium. One has to prime the phaco probe with the normal tip as usual. Then remove the normal tip and then attach the IOL slicing tip on it. These are the forceps which help in holding the IOL through the side port. They are ergonomically designed. So once we've held the IOL, all one has to do is just press on the foot pedal, and it smartly uses the ultrasonic power of the phaco machine and the phaco probe to slice the IOL. Temperatures were checked at the tip of the IOL slicing tip and the tip of the phaco tip. Both were equivalent in temperature. The phaco power is kept at 30% power, There is no vacuum or aspiration as the tip is a solid metal tip. Good counter pressure has to be given as it's not a hollow tip and doesn't have any suction. How a piece of plastic is cut with a knife is shown here. However, if the knife has an ultrasonic vibration, it can even cut a piece of hard plastic. There are different tips for different phaco machines as the lengths of all differ. When will you need this? The lens just shoots through the cartridge and creates a posterior capsular rent, or a trailing haptic gets broken at the time of injection, or a leading haptic. You never know when you will need it. Broken haptic complications, opacified IOLs, bag lens complex being dislocated or subluxated, trifocal lenses not being tolerated, a refractive surprise which we will see more and more in our post-LASIK cases. This can be kept aside or ETO'd and put aside just like a vitrectomy cutter. We keep a lens slicer. This is so smooth like butter that within 1 to 2 seconds the lens is cut. One method over here I am using where I have used an IOL scaffold. This was a patient intolerant to the trifocal lens. It was a toric lens as you can see, but in spite of all that, one has been able to cut the lens easily into 4 pieces. These are very tricky situations. Here I have used a scaffold to protect the posterior capsule in case of chamber fluctuation. However, sometimes we have an open posterior capsule also. You can see the new toric lens being implanted so well. This is a patient who had a YAG laser done. So first I had to cut the IOL, or rather slice the IOL into 3 parts, and then I have implanted a 3-piece in the sulcus. The other use of this tip is taming the hard cataract. One has to do just the way one does a horizontal chop. The only difference here is that in the horizontal chop, the phaco probe or the phaco tip is holding the cataract with a vacuum with your right hand in a right-handed person, and the left hand is going around the equator and pulling the chopper towards the center. Here we are stabilizing the cataract with a stabilizer which has a ball tip and keeping the left hand steady, and then with the right hand using the same tip to cut through the hard cataract. Here we can see the first chop was made like a chopper. Therefore it has fluffy white edges. But now as you see, when the next chop is going to be made, I will be pressing on the foot pedal, and because of that this chop is very smooth and has clean borders or clean edges. One has to become familiar with doing the horizontal chop and having the confidence to go around the equator to stabilize the nucleus. One can first practice doing the horizontal chop on soft cataracts and then doing it on hard cataracts. Here this is to demonstrate how chewy the cataract and leathery the cataract was. Thank you so much, Dr. Neha Dholakia.
So I have personally used this, and I think it's an extremely intelligent and handy device to have. But all of you all are very prolific surgeons as well, so I want to know if you have any experience with this. So what would be your preferred method of IOL cutting and explantation?
I use IOL bisecting scissors or some types of anus and then remove it. But I wouldn't mind trying this, you just don't have access to it.
Sir?
Yeah, I've used this. It's an interesting tool, works well, but in very thick lenses, suppose it's more than 25 diopters, then it's a little difficult to cut. Also, don't keep the same phaco parameters, because this basically is a solid tip. it's not a hollow tip like a phaco tip, it's a solid tip.
Right.
So you need not keep, vacuum and flow rate and all that. So what I see is most people, putting some flow rate and vacuum, and they'll have that occlusion sound always because
Right.
it's not a hollow tip. So you just need phaco energy and put viscoelastic, and with the phaco energy you can
So
do
she
the
used 30, you also use around
yeah.
that much power?
30 to 50% continuous power. You get different tips for different machines. I think I have the one which works on the Centurion, but it should be okay on any phaco machine because all phaco machines you can put for continuous linear power.
Yeah.
I usually keep it at about 50, 60 and then, but you may require anywhere from 30 to 50%.
Quick question. Would you not need some amount of flow and to maintain the tip cool?
Vacuum, I'm talking about vacuum. Some amount of flow can be there. Flow means not the aspiration flow rate. See, I'm talking about flow rate and vacuum. Irrigation will be on.
Does the sleeve go around it?
Yeah, the sleeve goes
Sleeve
around.
goes around.
You need a sleeve because
So-
you have the regular incision.
Yes.
So you put your irrigation sleeve and you have continuous irrigation because you need cooling and chamber to be formed.
Otherwise you'll get a wound burn.
Otherwise you'll get a wound burn.
Yeah.
It's not a hollow tip, it's a solid tip. So there's no point in putting a flow rate or a vacuum.
Nothing is working.
Nothing's working.
Another thing to remember is that it looks like a scissor, but it's not behaving like a scissor. So it does not, like she mentioned, the tip does not move in and out. So we will need to actually give counter traction with the forceps that she has to get the cutting movement. So it's one-dimensional in that.
You need counter traction, so
Yeah.
you need to have something to stabilize the lens. You can use a micro forceps, any micro forceps to hold the lens.
She has designed one to
Any
go with
micro
this
forceps.
scissor as well, yeah. So we'll move on to the next talk. Thank you. So I will be speaking on nuances of hydroimplantation and management of flipped IOLs. So the first question I get when I bring up hydroimplantation, especially with a friend that is not doing it, is why hydroimplant? When we have visco and it is serving us so well, why even take the trouble? Is there an added advantage? I mean, visco seems almost perfect, but yes, there is a role of hydroimplant. So we all know that retained visco can cause post-operative IOP spikes. So it is very important to take it out, and this increases surgical time, which is very precious for us in our busy practice. Retained visco can also push the IOL forward, causing change in refractive power, and retained visco can also sometimes alter toric IOL alignment. And in high volume setups, there is also a cost implication to the same. It's interesting to note that it's really not a new concept, and it has been around, and people have tried to use this in different forms right from the beginning of phacoemulsification. So what we do in hydroimplant is try and maintain chamber depth and stability through active irrigation instead of using viscoelastics. So the next question would be, is it safe? Okay, if we are replacing visco with something, is it still equally safe? And yes, it can be safe as long as we follow some important nuances. The first and most important thing for hydroimplantation is to avoid wound distortion. So we must be sure that the chamber is stable always, and make sure the plane and the direction of entry is right to prevent fluid loss. It's very important to make sure there's no fluid egress even from the side port. The cannula and the entry should be properly sized, and if needed you can also tilt the irrigation cannula and direct the fluid jet towards the PC to deepen it up to make sure the chamber is stable. Once the chamber is stable, more or less it's pretty straightforward. Second thing is, I like to run the cannula across the IOL, at least across the midline, to prevent flipping of the IOLs, which can sometimes be a problem, especially in hydrophobic IOLs. Like here, because it's running across the midline, everything is going perfectly fine, but we'll also look at some scenarios where things can uh, not be very perfect. So the next question would be, if all IOLs behave similarly, we have hydrophilic and we have hydrophobic, are they all the same? The answer is no. Hydrophilic IOLs tend to be more predictable. They inject, they open up very predictably, and they're easy to start with, especially if you're beginning hydroimplantation. Hydrophobic IOLs, once mastered, can be pretty easy, but initially they may have some issues, like they tend to shoot inside the eye, especially if the AC temperature is very low, and sometimes they may also flip or vault in the eye. To make hydrophilic IOLs safe for hydroimplantation, it's important to inject slowly and let the lens unfold on its own. Once that is done, just a simple rotation will ensure it is in place. For hydrophobic IOLs, we need to be a little more careful. We need to make sure the incision size is right so that the IOL is not shooting out at any point. I like to run the cannula across the midline like I told you. Make sure the leading haptic enters the bag, after which I personally like to use a second instrument to dial the IOL in. So this does fare better than conventional implantation in some ways. Like we discussed, we are using lesser fluid in these patients, lesser surgical time, there's lesser chance of IOP spike, and better toric IOL stability. But there should be some precautions that should be followed, especially by beginners. It's probably best to avoid small pupils when we are starting with this procedure. Avoid shallow AC, zonular laxity, pseudo exfoliation. If you're a beginner, then watch out for cases that have IFIS, very poorly cooperating patients, and definitely avoid it in weak capsules. But the most important thing for hydroimplantation is that the chamber should be stable and AC should be well maintained at all points. To summarize this, hydroimplantation is a safe, efficient and cost-effective method as long as we follow basic nuances like avoiding wound distortion and maintaining chamber depth. Look out for the kind of IOL you're using and anticipate its behavior. As long as you're following these simple steps, hydroimplantation can be really simple. It can be predictable in most cases. And for all you know, you may all want to shift to this, and it may become your procedure of choice in most cases. Moving on to management of flipped IOLs. Now, we all have years of cataract surgery with us, and in most cases, everything goes perfectly fine. Like this case where I'm doing a hydroimplantation of a hydrophobic IOL, but just as I'm withdrawing the injector, the IOL begins to flip. And in a matter of seconds, it's completely flipped over. Now, once the IOL flips, can we leave it like that? Is it really such a big deal? Will it make a lot of difference? Now, let's see what's happening inside the eye. Now, in the eye, the IOLs are designed to have a posterior angulation, which means when the capsule contrasts, it is snugly sitting against the posterior surface. Now, if we were to flip the lens and leave it like that, when the capsule fibroses, there is more space than is needed under the optic, and this is going to increase chances of PCO. So always, please flip it. Now we also know the anterior surface of the lens has asphericity in it. So if we were to leave it as it is, we would lose that property, and forward vaulting can also cause change in refractive error. So like you can see here, the IOL is completely flipped. I'm going to continue with hydroimplantation and just make sure that I tuck the leading haptic under the capsule. Once this is done and a part of the optic is in, the lens is able to be flat again and then just dial it in. Now let's see why this happened in the first place in this lens. Like I mentioned earlier, with hydrophobic IOLs, it's important to run your irrigation cannula across the midline to support it. Now, like you can see in this case, this irrigation fluid jet is hitting the edge of the optic. Now, because it is hitting this at this particular position, the jet is pushing the IOL and causing it to flip. So, if you run the same cannula across the midline, then instead of causing the tilt, it will actually support it downwards. Now, this is another case. Like you can see, the irrigation cannula is more towards the center, and this is a hydrophilic IOL, so this is more predictable as well, but here the optic is flat into the bag and less complicated. So in this case, the summary would be to support the optic with your irrigation cannula, especially in hydroimplantation. And if the lens is flipped, please do not leave it like that. Make sure the AC is fully formed either with viscoelastic or with irrigation to make sure the chamber is stable. Now here is another scenario where I am implanting toric IOL, and like you can see, the leading haptic is twisted. Now at this point I notice it and I turn my injector so that the trailing haptic at least is in the right position. Now we have a twisted leading haptic, and if we were to wait just a few seconds more, you can see it is again starting to flip. So it's important to be quick to notice and to act in these cases. So I go ahead and tuck the optic and the trailing haptic inside. Once this is done, it becomes very straightforward again. So the takeaway from this case would be to make sure to watch the behavior of the leading haptic, and if needed, twist the injector to make sure at least the trailing haptic can be in its right position. Now that was with single piece IOLs. Now 3-piece IOLs can be trickier. In this case, it is loaded wrong, so it is completely flipped, and by the time I notice, it's a completely flipped IOL in the bag. Now please notice what I do is I leave the trailing haptic out. This is very important, especially if we need to flip a 3-piece IOL. Once this is done, the basic thing would be to fill the AC to make sure we are protecting the posterior capsule as well as the endothelium. Now, because the trailing haptic is out, we are not worried about it scraping on the endothelium. So I use a second instrument to support one end and then just flip the optic over. Because of the orientation, the leading haptic is not going to scrape the posterior capsule, and then once the optic is flipped, we can always dial the trailing haptic in. So in 3-piece IOLs, like any other case, please make sure the AC is well formed and protect the endothelium and posterior capsule. Keep the trailing haptic out until you finish flipping. Thank you. Dr. Sri Ganesh, what would be your preferred method? Do you like doing hydroimplantation or do you prefer viscoimplantation?
I always do hydroimplantation, but I don't use an irrigating cannula. I don't use through the side port. I just form the AC with BSS and inject. I've been doing it. It makes your surgery faster because it reduces 2 steps, putting in the viscoelastic and removing the viscoelastic. Also post-op IOP spikes are less because you don't have the visco, which is, you can never remove HPMC completely. That's one thing. And then for toric IOLs, we actually did a study between hydroimplantation and with visco. For toric IOLs, I find that the rotational stability is better with hydroimplantation, because when you use viscoelastic and you don't remove all the viscoelastic, immediate post-op there is a spike in the IOP. When there's a spike in the IOP, the bag also opens up. And especially in myopes, that's when the kind of lens can rotate within the first couple of hours. And if you do a hydroimplantation and at the end of it you keep the eye a little soft, you can actually see some folds in the PC, then you are sure that the bag has collapsed over the lens and it doesn't rotate. So we find that the rotation is better. The only contraindication for me not to use hydroimplantation and use a viscoelastic is when there is anterior vitreous detachment. So in some of the older patients, you have anterior vitreous detachment because of a weak Weger's ligament. So how do you recognize it? When you are doing your IA, you can see that the PC keeps, the Weger's ligament holds back the PC to the anterior hyaloid face. So if you have a weak Weger's ligament, then what happens is the whole PC keeps fluttering up and you have a higher incidence of PCR when you are doing IA. So how you recognize this is, you can see some small particles behind the PC. We call it tobacco dusting, also publishing it. So this indicates that, you know, the small cortical matter has gone through the zonules, and generally if the Weger's is there, it prevents it to go behind the PC, but then it goes behind and you can see that, and the PC, if you do a intraop OCT, you can very clearly see that there's a big space between the PC and the anterior hyaloid. In such cases, when you are doing hydroimplantation, there are two things that happen. The PC comes up. So when you are injecting the PC is not kept down, you can tear the PC and the lens may not go comfortably in the bag. The other problem is you can cause a vitreous hydration. The fluid can go through the zonules, hydrate the vitreous, and you have like a aqueous misdirection syndrome where you suddenly have a very shallow IOP, high IOP, and you're not able to inject the lens. So in these cases, once I recognize that while doing the IA, then I put viscoelastic, because with viscoelastic it pushes the PC down. The PC is not fluttering, and then you can safely inject the lens.
Dr. Sudeep, I know that you've been doing hydroimplantation for years. Is there anything you would like to add on?
No, what he said is right. There, of course, there are certain IOLs which have a screw type injector. Like you have the Pure C, you have the iHands toric, where unless somebody else is injecting it, which I haven't had the guts to do, so there I would need a viscoelastic. And three-piece IOLs would always go with the viscoelastic because it can actually rupture the PC a lot easier. The other thing I wanted to say is, like you were showing how to implant the second haptic. So it's been years since I probably used a hydrophilic lens, but hydrophilics are very soft. The thing is they can flex anterior-posteriorly also. So what you did was right, you just pushed the IOL back and it went in. Hydrophobic IOL, because it's fairly rigid. You try to push it down against the iris, you will get hydrodialysis and bleeding. So you have to use a second instrument. Sometimes you can hook it with the cannula itself, but ideally with the dialer, and then you have to dial it in. You can't push it backwards against, otherwise, yeah, it's fine. And yeah, what you mentioned about flipping is right. If you have it on one side, it will flip. And the other one that you said must have been an old video where the haptic was twisted. So there quite a bit. So the first front haptic also goes in the right direction, and then turn it back again and inject the rest of the IOL. So twice, this way and then that way.
Dr. Matthew, do you prefer to do hydroimplantation, and if you do, is flipping often or not so much?
So I don't use hydroimplantation only for three-piece IOLs. That is strictly under visco, but all other cases it's under hydro. And flipping, if it is a anterior and posterior square edge, I don't bother to flip it again, and especially if it is a plano. If there is a vaulting, there can be a refractive surprise. If it is anterior square edge only, posterior square edge only, then the flipped lens will become an anterior square edge. So then PCO rates are high. But then I tend to balance and see whether risk of flipping it is higher than risk of a PC rent. Because in those cases, I'd rather do a YAG at a later date than try to have a rent intraoperatively.
So if it's a spherical lens, it doesn't really matter which way it is. The power remains exactly the same. I think on the Sri Ganesh, you said you just fill with BSS, and then, so your wound size has to be absolutely perfect.
Yes, your wound construction has to be perfect.
Fit the cartridge tip
yes.
exactly.
Exactly.
Yeah.
And with three-piece lenses, what happens is, because you don't have a solid haptic, okay, it's very thin, the haptic. So when it folds, there's a lot of space there.
Fluid.
Ideally, so the fluid comes back into the injector, so the AC does not maintain.
Yeah.
So that's why for three-piece lenses, it's not advised, because the AC maintenance with BSS is not good.
Yeah.
Because you have BSS coming in and then going out through the injector.
We'll now move on to our next talk, Surgical Strategies for Malposition and Flipped ICLs by Dr. Matthew Kurian.
Thank you, Dr. Soumya, for this invite. So, how frequently do we have ICL problems? Approximately 0.2%. The secondary intervention is required, and this is from the FDA data as well. And the breakdown of the secondary intervention would be for toric ICLs, where we are largely trying to realign it in about 0.2%, and high vault in about 0.1%. And these are more recent data because the formulae and the sizing options have become better over time, and I'll discuss that towards the end of my talk. Flipped ICL is actually pretty rare, and almost instantly, intraoperatively, you are able to recognize it in case there is a problem. So the main thing to remember for safe ICL is to load it perfectly, fill the cartridge with mixture of visco and BSS, avoid air bubbles because that interrupts your visualization, and then make sure that you remove the ICL carefully using a soft tip plunger and load it in the lens. The convexity should be upwards, and at this time identify the placement holes on the footplate, which is top right, bottom left, and the center hole, and once it is loaded, pulled into the nozzle of the cartridge, it should be all in a straight line. If it is twisted at that stage, the likelihood is that as you inject it, it will be coming in flipped. So this is the most critical step. Hold the ICL right in the middle near the leading hole, draw it, and identify that these three holes are in a straight line, and that will ensure that the ICL will not twist as it is coming, as being pushed into the eye. Lock and secure the cartridge, and most importantly, reduce the time from loading to the injection to the shortest duration. This is what happens if it sits in a cold air-conditioned operation theater for a long time. 5-10 minutes, this will refuse to open. You need to explant it, unfurl it, and then reload and inject it again. Hold the lens always in the center, not in the side, because there you can see a little bit was torn off. Incision construction is very, very critical. Your intraoperative microscope should show that the blade is exactly parallel and it's not tilted to either side, and it should be adequately sized. 2.8, 3.2, too small, difficult insertion. You're doing a wound assisted insertion, and the ICL will tend to have some friction against the side. Too large a wound, iris prolapse, will cause difficulty at the end of the surgery. However, unfolding the ICL depends both on proper loading and a good perfect wound construction, but that is not the end of the story. Because if you do a wound assisted implantation and the lens is rubbing one side of the wound as it is going inside, it will tend to flip, and you will be able to identify from the positioning holes, top right, bottom left, that it is wrong. You need to pull it out and then re-implant it. And this is the same thing that happens. Friction on one side, smooth on the other side, the ball swings. Similarly, the ICL also swings. Complications related to toric IOL, you have to mark the axis perfectly. If you don't have a Varion kind of system, then you can do it on the slit lamp. Intraoperative marking is based on the reference marking. So the quality of the reference marking has to be perfect. This is an individual who had toric ICL. You have to make sure that there is no HPMC, if you're using HPMC, between the crystalline lens and the ICL in the vault area before you finally size and leave the lens there. Most complications are related to sizing. Too low a vault, there is no nutrition for the anterior lens capsule, so a cataract develops even if there is no physical contact. Exchanging it for a cataract surgery is relatively stressful for the surgeon. And here we have a situation where we want to we have an oversized lens and we are trying to explant it. So put visco on top, put visco, float the ICL subincisional haptics into the angle, and then you can use a hand over hand technique with the Ostherow forceps and a McPherson to explant the lens. In an exchange, the anterior lens capsule needs to be very carefully maintained, no trauma, the pupil dilatation needs to be maintained, and you need to make sure that you're not flipping the lens over all over again. The tucking should not be at the haptic optic junction, but should be at the haptic footplate junction. That area actually folds very easily, and good amount of epitrate or some pupillary dilating mechanism is required, especially in a exchange case. So gentle iris handling, minimum maintain the appropriate distance during the instrument manipulation to avoid any anterior lens capsule trauma. So these are the critical steps to remember. The vault is the greatest problem. If you have access to intraoperative OCT, you can actually see that it is well positioned, and IOP fluctuation actually does not cause much of an intraoperative change. This is a gentleman who went for a facial a couple of months after the cataracts, after the ICL implantation, and continuous massage in one direction caused the lens to properly sized lens to rotate, and we were able to sort it out using just irrigation and using the Vukich manipulator. So most of the time we are using the white to white as the reference for sizing. The OBSCAN 2 was probably the best. All other devices give different sizes for the white to white, and they need to be titrated to your clinical condition. High vault is more than 1000 microns. Low vault is less than 125 microns, and in a vault exchange here we have about 1600 microns after a 12.5 was implanted. This is the V4B, and exchange to a 12. So there is a reduction of about 0.6, 0.7 mm in the vault, and in the second eye we have used a 12.0 based on the sulcus to sulcus measurement and got an appropriate vault. The direct measurements using the sulcus to sulcus is probably the best, and the STS UBM has indicators for posterior lens, anterior lens, posterior capsule, right and left sulcus, sulcus to sulcus, and when all of those have been identified, the apex is also lit up in green, and this tells you that your measurement quality is good. It gives you the central and the mid-peripheral vault as well. It predicts that. The IOL Guru, ICL Guru is something that has come more recently, and this uses AI to identify that you are in the correct horizontal plane, all the vertical items are correctly mapped, and the largest posterior capsule image is taken, and you can see on the top right over here there is this green indicator. It tells you whether the quality of the image is good, and selected images are taken to the ICL Guru, and if it is yellow or red it is discarded. Green, good quality images are taken, and then it gives you this kind of a predicted vault. The mesolytic biometer is based on the white to white, and it gives predicted vault based on the recommended ICL on the Stella or Orcos platform by Star Surgicals, and the ICL Guru gives this kind of sizing, central and peripheral vault as well. Now issues come where in this kind of a situation the right eye has been predicted, advised by Star Surgicals to go for a 13.2, but the UBM says 12.6, much better predicted central vault as well. When it is consistent, there is no problem, but where there is discrepancy, there is an issue with what you want to do, and with experience people probably take a decision towards undersizing or oversizing depending on the clinical situation. The other good thing that the ICL Guru gives is for toric lenses. Here you have two lenses which are supposed to be giving perfect vaults, 0.35, 0.5 perfect vaults, but the stability is lower, and so in a toric case you would probably want to go for something which is more stable rather than something which is likely to rotate. So here I have a situation where UBM showed me that it was a normal sulcus, walls 500, 400, slight variations over days, but intended axis and achieved axis completely off. Final, before we exchanged, there was a 4.5 cylinder in the right eye and a 175 cylinder in the left. And this is probably a situation where vault was okay, but stability was poor. Implantable columnar lens, I did a quick literature search. There is one report of a flipped ICL sitting in the eye for 10 years, and poor quality vision was noted almost very soon after the implantation, and this anterior capsular cataract required a cataract surgery which was deferred for 10 years. So realignment in toric ICLs, if there is deviation which is symptomatic and in the presence of a vault which is adequate, you want to realign, and you can observe it if the vault is if the astigmatism is tolerated. If there is a vertical rotation, we can consider for an excessive vault, because in some individuals the vertical sulcus to sulcus may be larger than the horizontal sulcus to sulcus. This is possible only if it is a non-toric lens, and you have to measure the STS directly using a UBM and confirm that it is a larger vertical. Then the ICL exchange, you would consider oversizing. You would exchange for a smaller lens if it is oversized, when there is an excessive vault, when there is angle closure, when there is raised IOP. You would exchange for a larger lens if it is very low vault, which is almost touching. It's more forgiving with the center flow technology, and where there is a lot of rotation with the toric lens. And if it is a flip lens, you obviously want to get it out and exchange it in the correct orientation. So to summarize, it's excellent safety, corneal health is maintained, and high patient satisfaction, provided we go with these factors. Thank you.
Dr. Matthew, I know that now with the V4C model, we're all more confident of doing a low vault and maybe just waiting and watching it out. Would 100 microns be your limit for explant, or would you still want to wait and watch for some time?
With the center flow technology, there is flow through the anterior surface even in the center, so it's much more forgiving for low vaults. If it is likely to, I would be looking at the preoperative anterior lens rise. If the anterior lens rise is high, I would then not wait too long, but I would keep these individuals under very close monitoring.
Thank you, sir. We'll next move on to the next talk.
There's a question from
Do we have a question?
Do you consider the peripheral vault importance? Because two of my patients, central vault every time was 400, 500, about 450. And there was a peripheral touch, and when she developed a cataract, we realized that the periphery was touching the lens. And what is the guideline where you cut off that thing, that if there is a peripheral this much amount, it is something which you should be worried about? This was quite common in one or two makers, one, especially one. They rectified the whole thing, but what I want to tell you is that peripheral touch should we consider very important. I think Rishi Ganesh also might be able to answer this.
Yeah, basically you need to look at, do a UBM. That's why post-op UBM also is important, because you can look at the periphery and look at the peripheral touch. If it's like less than 100 microns, what happens is the natural lens grows about 20 microns every year. So in 5 years, you will have a touch, especially a peripheral touch. And peripheral touch is the one that actually causes your anterior subcapsular cataract. So it is better to exchange if there is an anterior touch, because you see that sometimes the lens opacities can reverse if you do it early. So that's the reason why you have to be proactive, otherwise the patient will require cataract. I would see 100 microns again, like I said, in 5 or 10 years, you may have to. So it's probably, you can watch it. If it's 100 microns, you can watch it. And if it comes down to like 50 or 40 microns, then it's better to exchange it before the lens touch.
Thank you, Dr. Matthew. We next have dislocated in the bag IOLs by Dr. Sudeep Das.
Thank you everyone. Thank you, Soumya. I don't have any financial disclosures. So when to refix and when to remove, and if you have sufficient experience and you have the skills to do it, almost all can be refixed except for a few. So if the IOL is damaged, then obviously you have to explant it. The other thing that I wouldn't try to refix is these hydrophobic IOLs with a single haptic. It's sort of dislocated into the anterior chamber and all. I wouldn't try to, so I had one of those, Matthew will know, one patient. So it was dislocated into the anterior chamber after an accident, so those you have to explant and put in a second IOL. And of course it depends on availability of instruments, facilities. So this was a sort of a subluxated IOL, one side zonal lux. So you can see the CTS there. It was fixed, and then capsular contraction, it's moved to one side. So here we decided to fix it with a capsule tension segment. The rest of the zonules are absolutely fine. So that was the CTS, which was fixed to sutures under a scleral flap. And then don't pull it so much that you will disrupt the zonules on the other side. You have to be very careful. Sometimes it will probably be a little decentered even after fixation, but that's okay. I mean, it won't be, unless you fully dilate it, you can't make out. So here this was a 3-piece IOL, which again the same thing had happened. It had got displaced to one side. And it wasn't, you couldn't see the haptic unless you put, so it was dilated pupil, but you see how putting iris hooks helps even more. So here we decided to just take a suture and just fix it. This was a very old surgery done long back. I mean the first surgery, there was a PMMA IOL. So these are Hoffman pockets that I'm making. And what you saw was a 300 micron preset blade. So you will not get more than 300 microns. So initially when I use making Hoffman pockets, it's better to use those preset blades. Later on you get an idea how to do it. So here basically I'm fixing the two haptics of the PMMA IOL onto the sclera. And this is with 9O Proline. So later on I went to Gore-Tex. So once needle sort of goes in and then you railroad the other one through a 26 or a 30G needle, bring it out. So the loop has gone around the haptic of the PMMA IOL. But you have to make sure that the direction is opposite on the two sides, otherwise it will rotate in one direction. So why I put in a Sinski through the Hoffman pocket before putting a needle in is I want to be sure that my needles are going through an area which I have dissected. If I go posterior to that, then I won't be able to retrieve the sutures out to knot them again. So here there is a possibility that it might slip, beyond the IOL might rotate and slip beyond the tip and again dislocate, but in a PMM IOL, the fairly large haptics, I haven't seen that happen. So once I take the loops out of the Hoffman pocket, tie them, the knots have automatically gone into the Hoffman's pockets on the both sides, and you can see that it's pretty well centered IOL. So the other option is you can fix these to the iris. So again, this was a displaced PMM IOL. You can see the bag is completely, I don't know what it was initially. There's a lot of pseudo exfoliation. So the bag is crumpled and completely fixed. So what you have to do is you have to bring the optic forward so that you can see the outline of the haptic against the iris. And then you take a sort of a, this is a PMMA, straight PMMA, Prolene suture, which I bent it. So it's a large loop. So you go through the cornea, through the iris, under the haptic, then out through the iris, out through the cornea. Then make a small side port there. You can use mechanical suture, but this is easier. Just pull the knots out, cut, and then, so this is basically what I'm using as a mechanical. So it goes through the cornea, through the iris. You can see the outline of the haptic here. So go through the iris under the haptic, then come out again through the iris, out through the cornea. Because the optic is now in the AC, you can sort of, it pushes the haptic against the iris and you can see the outline. So this has gone under the haptic. And then again, you cut the needle off and sort of tie it. And once that is done, of course, I have to remove that capsule with vitrectomy. Otherwise, the visual outcome will be pretty bad. Vitrectomy, and along with that, remove as much of the capsule as was can. And once that is done, you push the optic in. So this is very ovalized because I went slightly more central. But then if you do it better, then it actually you get a much rounder pupil. So this was a dislocated three-piece IOL, foldable. And you can actually do a scleral tuck in these cases also. So making this scleral flap here. So at now, this I'm using a side port, but now I would probably use an MVR blade. So again, you can see some capsular remnants. So I'm trying to hold the tip of the three-piece IOL. And sometimes it helps to do this. I was using a Sinski and forceps, but it's sometimes better to use two forceps, two intraocular forceps. And do the same thing on the other side. And remove the vitreous and all the capsular remnants. And once that is done, you just have to tuck this into a sort of a groove you made on the edge of the flap. So I would probably now prefer, I don't do this anymore, but the later surgeries I was probably using a 30G, not a 26G to fix this. And then you can either use glue for this flap or you can suture it down or whatever. So here I use glue to, for the flap as well as the conjunctiva. And I didn't show much of explantation because, like I said, most of them you can fix. But this is a PMM which was badly, dangling there. And I think this was one of those, somehow I didn't like the design of this, one of the older designs of PMMA IOLs. So nothing, you just, in a PMMA, you just have to extend the wound and pull it out. And the other foldable explantation, you saw a lot of them in Dr. Neha Dolakia's video. Thank you.
Do we have any questions for Dr. Sudeep? Sir, I know that you've done all sorts of procedures, but what is your preferred procedure for a secondary IOL implantation now in the absence of capsular support?
At present, I'll use the CMT flex. Almost always I'll use the CMT flex through various techniques. Flap, Hoffman pockets, scleral tunnel, something.
Thank you.
The easiest to do.
We move on to the next talk by Dr. Sri Ganesh on IOL explantation and fixation in complex situations.
Good morning everybody, and thank you Soumya for inviting me to this IC. So just a show of hands, how many of you all have had an IOL tear, either the optic or the haptic while implanting a lens? Okay, so quite a few. So I'm going to show you some cases where I've had this problem. I think if you have been implanting enough lenses, everybody would have kind of torn a haptic or the optic, and the techniques of explantation and reimplantation. Yeah, so let's go on to the first case, and here you can see that I'm injecting, this is a hydrophobic lens. It is a new EDOF lens, and then once I inject it, you can see that the trailing haptic again is not intact. This can happen with some of these injectors because the silicone tip can entrap the haptic between the sleeve and the tip, and you can have a torn haptic. So this is a thinner lens. Higher refractive index lenses, you can just, what I do is I just extend the internal wound. So I have a funnel shaped trapezoid wound. Then I go in with a microforceps, and then you can just do a twist and pull technique. So the funnel guides the IOL to fold, and it comes out easily. Because you're just extending the internal lip, you don't have much of induced astigmatism. Then of course you have your standby lens which you can then inject. And then it goes into the capsular bag. So the twist and pull technique is good for higher refractive index lenses which are thinner. This is the second case. Here I am injecting a hydrophobic, this is a CT Lucia, and you can see the leading haptic has torn. So these are preloaded lenses, so it's not a loading issue by the assistant. Sometimes there can be entrapment of the haptic, and usually you get a torn haptic. Here again, I always like to extend the internal lip because this makes, even if you're cutting the lens, it makes the delivery easier. Here I'm using the MST IOL cutter. So you hold you fixate the IOL optic, and then you cut 3/4, and then you can just use the microforceps, and then you can rotate it and remove it. You always have to rotate it clockwise, because if you rotate it counterclockwise, what happens is the haptic will get caught, the trailing haptic will get caught in the wound. And then of course you can just re-inject the standby lens. So why I like to kind of extend a little is so that the delivery is easier and you don't have much of corneal edema. This is a case, again, this is the Bausch & Lomb lens. So this, you can see the trailing haptic is cut. So this has a hole in the optic haptic junction. So I'm just stabilizing that with a Colestat dialer. So you always need the counter traction when you're cutting. Here I'm using the MST forceps, and then here, see, I'm twisting counterclockwise. When you do that, then the haptic will get caught. Then you have to cut the haptic. So then I go ahead, I cut it through and through. Or you either have to cut the haptic, or you have to cut it through and through and remove the two pieces. So it's the direction where you dial it out is very important. This is again a new lens being injected. As this lens opens up very slowly. So coming to the other case 4, this is a plate haptic lens, Zeiss lens, and again you can see the trailing haptic probably has got entrapped in the silicon tip and then it is torn. You can't leave it like that because again this will cause decentration and other issues. So here again I am doing the twist and pull. It's a thinner lens, so you can just twist and pull it out. So you can use different techniques. It's not that you have to use one technique. I also sometimes use the Dolakia device. This is a 3-piece lens. This is the Hoya 3-piece lens where the PVDF haptic is fused to the optic, and you can see while injecting, the leading haptic has just detached from the optic. So here I just hold the trailing haptic and then I cut the lens, but I am able to rotate it counterclockwise here because there is no haptic to get engaged in the wound. So you can see that, and then I remove that haptic which is there in the antechamber and put in a new lens. So some of you all who have used this lens could have had this problem. The fused haptic just detaches. This is another case where this was a post-ICL cataract. So I have done the femto and then I have to explant it. So what I do is I just put visco above and below. Then I go with the same loading forceps and I do the twist and pull technique. So of course Matthew showed the hand over hand technique. This is just a twist and pull. Then I remove the capsular flap. And that's not the end of the story because this is a high myope. I'm using an expand series lens here. It's a 3-piece lens, and then I inject it, and then you can see the trailing haptic. It's twisted now. So if it's twisted like this, it's unlikely that because of the memory it's going to become all right. And these high myopes again have large pupils, large bags. Now it's badly twisted. So then I go in and then I have to expand this lens. So I just use this is the MST cutter. I've also cut the trailing haptic, and then you also have to, then I just rotate it out, and then it comes out easily. And then you can put in the standby lens, and it's well centered. I'll also show you my technique of scleral fixation, which is so of course Samaresh is going to speak on the dead bag syndrome. This was a dead bag syndrome, so the lens, this is a trifocal lens, it had kind of dislocated into the vitreous, so the VR surgeon did a pars plana vitrectomy and brought out the lens in the AC. So I do a scleral tunnel, 6 millimeter scleral tunnel here, and that's explantation of the bag with the capsule. So just hold it with the forceps after putting viscoelastic, and you can remove the whole bag and the capsule. Then I use a preloaded 27 gauge needle with a 6O proline. So it's preloaded. So you just go 1.7 millimeters away from the limbus horizontally, and then you bring out the proline haptics, proline suture, and then you use a PMMA lens, scleral fixation, pass it through the eyelet, flange the proline. I just put in the leading haptic, then the trailing haptic again I pass the proline, flange it. You have to have a thermal cautery. You can't use a bipolar cautery on your machine. This is a thread burner which you can get on Amazon. Then you just push in the trailing haptic, then you just hold the behind the iris, then you hold the 2 threads, pull it tightly against the conjunctiva, snip it about 2.5 millimeters and then flange it. It has to be very tight like a rivet. If it's loose, then you can have extrusion of the proline. So that's something that you need to keep in mind. And after that, you can just bury it under the conjunctiva. With this technique, you don't get any tilt or decentration. So actually, this is my preferred technique. Though it's a PMMA lens, I also have a design where I can use a foldable lens. And I always put a suture in vitrectomized eyes for wound stability. So that's my technique. Thank you very much. If there are any questions.
Do we have any questions for Dr. Sri Ganesh?
What are you using for flanging? What brand of low temperature pottery?
This you get thread burners. You get it on Amazon. It's not the medical ones are quite expensive. Cost I think up 20,000-30,000 rupees. But this they're called thread burners. You get it on Amazon.
I was using
probably
a
cost
Chinese one.
2,000 rupees or something like
Yeah,
that.
I was using Chinese one, which at that time you could get in AliExpress. They use it for wax carving or something like that.
Yeah. These are called thread burners.
Yeah.
So they're not very expensive. 2,000.
They're very cheap,
3,000. Yeah. On Amazon you can get it. You put
And
it
they're
into batteries.
rechargeable.
No, you put it in batteries.
What
It's
I had
battery
was
operated.
rechargeable. You just
Okay.
put in a mobile charger and it charges.
This uses two AA cells. It's quite good.
You can also use spirit lamp with
Yeah,
bulb
but that's not
water.
very controlled,
not
and
Not
it's a
very
nuisance if
controlled,
it's
but-
not hot enough. Then you don't get a. The whole thing is you should not touch the proline. If you touch the proline, it becomes irregular and it can erode the conjunctiva. It should be dome shaped. So you just go very close so that you get a nice dome. So it doesn't erode the conjunctiva.
Thank you, sir.
Thank
If you touch it, it's charred.
Yes, it
It
does.
is burned and lost. So you have to heat it from a distance. Yeah. Sir, I have a question that when you are cutting the lens straight and try to pull it, so the other end is try to hit the angle and iris.
Yes.
So many times it should create hyphema.
Yes, so the direction is very important. So you have to always rotate it clockwise. So if you are rotating it counterclockwise, make sure to cut the other haptic. Otherwise, it will engage the iris, it will engage the wound, you will have more corneal edema, you can have hyphema.
Or you can remove a pie, then also.
Yeah, otherwise you can cut it into, bisect it or multiple pieces.
Thank you, sir.
Thank you, sir. We next move on to the next talk. We have a very interesting talk by Dr. Samresh Srivastava on dead bag syndrome.
Thanks a lot, Dr. Soumya. This is really a great teaching course. So I'm going to be discussing very briefly in the interest of time, dead bag syndrome. Dead bag syndrome or late decentration or dislocation of lenses are those patients who've had cataract surgery, uneventful cataract surgery, and will come to your clinic with good pseudophakia year on year, but after a decade or 2 decades or 2.5 decades, there is a spontaneous drop in the rupture of the posterior capsule with intact zonules. The type 1 and type 2, there are 2 types of dead bags. This term essentially is coined by Dr. Samuel Maskett, and this is typically how it would appear. In a patient who had good pseudophakia, the posterior capsule generally gives way for no apparent reason, and you'll realize last year you saw a patient which was absolutely well-centered lens, and the next year the patient is coming with a lens that's tilting off and falling down. And it can show up as many variants, like here it's almost a sunken lens. And more so. The other type of, or type 2 dead bag syndrome is the dislocation of an entire capsular bag IOL complex where the zonules weaken up, then the whole thing will fall down. And this will come as mostly with hydrophilic lenses because there's contraction and phimosis, and you can see the zonules are pulled and the entire bag moves on one side. Either posteriorly, or as you can see in a hydrophobic lens, this is an acrosoft, the entire bag IOL complex has moved ahead in front of the iris. So in our center we did a prospective study which is now published. It's the first part we discussed was the clinical features. So this is what we saw from June 2021 to 24. We saw 90 eyes in which about 40% had complete capsular bag IOL complex dislocation, but more than about 60% eyes had rupture, spontaneous rupture of the posterior capsules, which means the zonules were intact but the posterior capsule was gone. So this is how it looks in almost 30% of the eyes, the entire IOL was fallen down, landing up right in the vitreous cavity or sitting on the retina itself. This is just to show you, same patient with two different scenarios, about 20 years down the surgery. Right eye has a PCR but a stable lens, left eye has a PCR in sequential follow-up as well. And this is again same patient with one eye hydrophobic lens, second eye a three-piece lens, showing same situation happening. It can have a symptom of spectrum of manifestations of posterior capsule rupture, which means it could be a rupture with the lens dislocation or a standard lens. There was a predominant gender bias, so most of these patients were male patients for some reason. And the mean time interval was from 10 to 20 years. That's when the maximum number of patients did turn up with an uneventful. This is a single surgeon cataract surgery, because our practice at that time was being operated by one particular doctor only. So most of those patients were between 10 to 20 years of the primary surgery. There was a slight preponderance towards myopes having this more than the metropic eyes. And there was, and interestingly, it was the hydrophobic lenses that showed more dead bag syndrome than the hydrophilic lenses. When it comes to surgical management, there are many ways to fix it. We've seen so many ways, so I'm not going to discuss the steps in the interest of time, but you can do a transscleral fixation, which would be, in our case, the preference is to use a Gore-Tex suture, which we were using for the longest time. Gore-Tex is an off-label use to stitch these lenses onto the sclera so that they do not lose memory and they stay in place. Now Gore-Tex is not available over the counter, so it has to be arranged, but I'm not going to show it in the interest of time. Patients do very well with Gore-Tex. Only thing is you need to know how to handle the suture and bury the knots, otherwise you will develop granulomas, which are very difficult to handle. We published this a few years ago in the JCRS on our long-term follow-up of scleral fixation with Gore-Tex IOLs. But now we've nearly completely moved on to intrascleral fixation using the Yamane technique. It's very important to understand that you need to team up with a VR colleague. You should not do it on your own, because these eyes are compromised and there may be a retinal component posteriorly for which thorough checkup needs to be done. I'm just going to skip this surgery, but just to show you that this is a type 1 with PCR done, PCR and the lens fallen posteriorly. But notice the high amount of sommerings and nearly clear posterior capsule. This is very, very typical of a hydrophobic lens, which does a good shrink wrap around the lens. You will have a thick sommerings ring, but typically your visual axis will be clear in these square-edged IOLs. And this is typically the scenario that we see. So now we are using two DMEC forceps to tease out the bag, because the VR colleague is going to do a 3-port pass planar vitrectomy, for which the ports have already been put. So we take out the entire sommerings en masse out of the main port, and then we go ahead and do a vitrectomy in this eye. So I'm just going to move ahead to show that and this is the explant of the IOL. Once you remove the IOL can be used to remove through one of many cutters. Dr. Sriganesh has shown so beautifully and elegantly how you can explant these lenses, and then go ahead and fixate. But once it's fixated, you need to make sure either primarily or retina surgeon needs to go posterior. Like in this patient over here, he did manage to find a break which had to be lasered when he was doing a vitrectomy in the ora area, and if the thing was missed, it would have landed up in a retinal detachment later. Patient also had an ERM for which the peeling was done, and that's why, because chronic inflammation, moving lens on the posterior segment may induce these inflammatory changes in the eye, which may need to be addressed. This is how the patient looks typically after an intrascleral fixation, and these lenses do phenomenally well. I have happier intrascleral patients than I have happy pseudofix in my eye, my patient cohort. I guess just because these lenses do very well if they're measured well. This is to show you how a lens fixates. On a UVM scan, it's a very fairly stable central lens if your measurement is done right. But the golden question to answer to end the surgery is, why does it happen? We did a histopathology of these explanted capsular bags, and we saw that the posterior capsule was typically dead, delaminated and split, and there were thick sommerings rings, as I showed you previously, the one that we explanted. What we believe happens is, on seeing these slides, is there is absence of lens epithelial cells, and these lens epithelial cells that are there are actually not normal, they're abnormal. So it is basically the fibrosis that is being caused by good lenses that we are right now chasing clean posterior capsule. But a clean posterior capsule also means sequestration of these lens epithelial cells, causing hypoxia. the LECs die, and eventually the capsular bag also dies because it doesn't get oxygen in supply. And so it dies and it just splits open at some point in time. So we also did a genetic analysis of these patients, whole exome sequencing, and we found 6 variants that are predominantly there in patients who had red bag syndrome. So there could be a genetic preponderance towards this as well. So again, what we hypothesized is that there is a genetic preponderance where LECs will go programmed death or they will die, and the posterior capsule loses its integrity. To conclude, we need to understand when the patient asks us, will I need to change this lens in the future? The chances you will have to tell them that they may have come down sometime later with a lens that has fallen down into the posterior compartment because of a dead back situation, and this is going to turn into an epidemic few years from now, where all our clinics we are going to see patients walking in with this. We need to be prepared in our mind and in our skill set to be able to handle these. Thank you.
Thank you, Dr. Samresh. Can we take questions later? Is the next session getting late? You want to? We can take one question.
We can take
Just
one.
one thing, it's very often also when patients have pseudo-exfoliation that this ends up happening.
Yes.
That's a whole lot, a big scenario.
Yeah.
And the other thing is, you said about it could also be that people are not doing proper cortical cleaning of the periphery, and that's the reason why so much of Schomburgk's
Yes. Even with the best cortical cleaning, you really cannot take out the equatorial LECs at certain point in time. But it's that fibrosis, that fibrosing of the lens against the posterior capsule, which really throttles down the LECs. So they just, because they cannot breathe, they're choked and they die.
Because I've seen a lot when I was in Kerala, there was a lot of pseudo-exfoliation there, and that caused the...
That's very likely a cause also.
Dr. Samresh can take the questions off the dais, and we just don't want to delay the next session. And before the next session starts, I request our faculty to come in for a group photo.